Welcome everyone. Koyana, Chamai, Waka. My name is Malia Villegas. I am a tribal council member from the native village of Afognak in Alaska, down in the Kodiak Island area. So very honored to be with you today, to be asked to help facilitate this amazing group of experts and researchers, medical professionals on behalf of Indigenous communities in this arena. As the world continues to grapple with the COVID-19 pandemic, the Center for Indigenous Cancer Research, or CICR, at Roswell Park Comprehensive Cancer Center is hosting this virtual conversation as it relates to cancer care and coronavirus with Indigenous communities. We want to specifically acknowledge Dr. Rodney Herring, Director of the CICR, for coordinating this virtual fireside Zoom chat. You'll see a fireside behind at least one of our esteemed panelists. Thank you for bringing that, Ms. Nina Scott. And really want to thank Dr. Rodney for bringing together this awe-inspiring group of Indigenous cancer experts and practitioners from across the nation and worldwide. Dr. Herring has said that when a health crisis like what we are seeing with the coronavirus starts affecting people on a national and international level, a lot of the support resources from prevention to treatment and survivorship are not indigenized. This is one of the first international forums to bring together Indigenous experts to share knowledge around cancer and COVID-19. So thank you for sharing your time with us today, all of our panelists and participants. So I'm going to go ahead and start off with some questions, and I'll direct them initially so we can have our panelists all participate, but we encourage you to submit your questions through the chat and Q&A features, and we'll hopefully have some time towards the end of this 1.5 hour session to bring you some questions from the group here. So I'm going to go ahead and start off with my northern colleague, Dr. Evan Adams, with a question of why do we need an Indigenous cancer patients and survivors focus during the COVID-19 pandemic? Why do we need that focus?
Hi, it's Evan Adams. I hope you can hear me. I'm calling you from Tla'amin Territory, which is near the city of Vancouver in Canada. And I work as the Chief Medical Officer in Public Health for about 200 different First Nations. And we know from our work that Indigenous people on a cancer journey have very unique stories and experiences that are different from other persons on a cancer journey, very much related to their very unique circumstances. And we know from speaking to Indigenous peoples on a cancer journey that they're often older. And certainly in my territory, there are elders. Older people, our elders, our knowledge keepers, on a cancer journey need support, and COVID, I think, has sharpened that focus. There's a lot that we can do to protect them.
Anna, thank you for that, getting into some of the demographics of who's experiencing some of these impacts already and how we can address some of their needs. Shift to the South lands here. Ms. Nina Scott, what are some of the greatest cancer-related challenges to Indigenous populations with the COVID-19 pandemic that you folks are seeing? What are some of the cancer-related challenges?
So when COVID first hit, I think a response of a lot of our treatment centres was just to shut down and stop doing the investigations for people with suspected cancer, stop doing the diagnosis, the diagnostic investigations in that first part of the cancer journey, as well as the treatment part. And we have problems with that first part of the journey anyway. So for Māori, have a longer wait time for, and it's harder to get into that system. So that's been a huge problem. People with signs that may be lung cancer and not being able to get a chest X-ray, for example. So we've been, the Cancer Agency, which is newly established here in New Zealand, is working in partnership with Hei Ahuru Mowai, which is our National Māori Cancer Leadership Group, and developed up prioritisation ladders requiring hospitals to provide a minimum standard of care for each level of COVIDness. That we have 4 levels, and so now those pathways have been unblocked, and people are now able to get back into that early diagnosis, and the treatments started to happen again. Because currently we are, like in my local hospital, which is one of our biggest ones, and my local area, we've got the highest rate of COVID in my area. We've got 1 person diagnosed in the hospital and 15 suspected. So it's kind of, we're kind of late starters, which is good. So our specialists and us, we still have space to do the cancer stuff. COVID hasn't overtaken us yet. So we're trying to push through the diagnosis case, people to be diagnosed. That's just some of the issues. And then also, you know, our highest death rates are in the older group, and those with other long-term conditions and comorbidities and multi-morbidity. And we know that that's a problem for Indigenous people worldwide, and that people with multi-morbidities and comorbidities are under-investigated and under-treated for cancer anyway. So we're battling that as well, because prioritisation, the risk is that, you know, you prioritise the things that are curable, and the risk is that people with comorbidities will be pushed out, and that's us. So we are having conversations nationally around, you know, it's a very difficult conversation, prioritising Indigenous people over non-Indigenous peoples in the clinical space, and at that really decision-making level about who gets treatment and who doesn't get treatment. And we're having those conversations and figuring out, because our death rate over the age of 55, it's twice as high anyway annually. We've got a twice as high risk of dying per year, and the COVID itself, and then the COVID-related under-treatment for long-term conditions and cancer really run the risk of blowing that up hugely. So we're trying really hard to manage that on multiple fronts.
I hear you talking about the risk. You know, I'm so glad you brought up comorbidities. I know nationally here in the U.S., it's a lot of focus on diabetes, if at all, but I'm really glad you're talking about the cancer aspects of that, and this issue of scarce resources and how practitioners and families are having to think about this in systems. So thank you for that.
Somebody's saying that the audio is very faint, so how do we
speak up? It's great. Not sure if all the panelists heard that, but yes, we should speak up a little bit more for the audio. Thank you for that. We'll head back over to New York, Buffalo, with Dr. Rodney Herring. We have a question here. Stress, anxiety related to COVID-19 are a growing concern, stress and anxiety. From an Indigenous perspective, what can cancer patients, families, and communities do to alleviate these potential stressors?
Well, Newiskano, Pugwego, from the Haudenosaunee territories located throughout New York and Southern Ontario. That's a very good question, because a lot of our, you know, surrounding COVID, there's been a lot of stress and anxiety in our communities. And it's part of that is, you know, due to a lot of the unknowing things that are occurring. A lot of information is going out. A lot of things are happening in relation to not only our communities, but our neighbors and our neighboring Indigenous communities and our non-Indigenous communities. So there is a lot of stress and anxiety. And from an Indigenous perspective, and you know, as you may or may not know, by training, I'm a social worker, and I've been in the field as a clinical social worker for over 15 years, and really, you know, one thing that I noticed, and you'll see that in the literature too, that a lot of our anxiety can be, stress can also be looked at from a cultural standpoint. You know, where did this come from? And how do we find resiliencies in it? And a lot of it's tied back to our culture, connecting back to our indigenous ways of knowing. And for a pandemic like this and things that are unknowing, it is very unsettling. But there are ways to look at that, connecting back to some of our indigenous physical activities. For us here, one form is lacrosse. Lacrosse is our medicine. So getting out and playing in your yard, getting outside and seeing things, going outside is part of that. Not staying inside, but going outside in the Northeast here, things are starting to bloom, starting to come alive. And part of that is our medicines that come in through, the springtime, like our wild onions and our traditional teas that help us when we use them in a good way to help, for example, some inflammatory process that's part of who we are. We do that as a people every spring. The sap that comes from our maple trees. These are all indigenous ways of really reconnecting and bringing that back. But what I would say is that, it's good, a lot of our communities are talking about that. And there's a lot of webinars, there's a lot of things that are but what I would say to community and community members and cancer patients and survivors and families that are working with cancer is to actually go do that. It's good to really look at, and listen to these things. But it's even better if you walk out that door and, go pick, soon it'll be here, it'll be wild strawberries. You need to get out and do that. And that's really part of, our medicines to ourselves, that we find that appreciation for the medicine, the love for these medicines, and carry that forward, and not forget that. And not to forget, like you're saying, a lot of the co-occurring conditions that are happening. So COVID-19 is there, and it not only affects perhaps cancer patients and survivors, but many of our communities do have diabetes. So we have to be extra vigilant on how we go about in our communities in social distancing and in respectful ways. But part of that, you really need to reconnect with your indigenous ways of knowing. Look at some of our ancestral medicines in a way that we've been using them to keep healthy, in combination of, the westernized medicines. So physical activity, keeping a good mind about the way we go about things, and not to be stressed out as much, and really connect with our elders. Check in with those that are going through some of these issues and concerns, whether they're a patient or back into the community, and to really look in and call them, do a virtual chat, anything you can to connect and make sure and engage them in perhaps a survivors virtual work group, for example. Start that in your communities. Make sure that everybody is on the same page and in a good mind, doing good things. And both our elders, but also our children. Our children are also going through a lot of these things that are concerning in our communities. And we have to be strong and keep that good mind so that we can make sure that they're of healthy mind too, and they're not scared. When we look, some of that are things in nature tell that story too. I mean, we look at, for example, now soon the blackberry bushes will be coming up. And within that tells a story too about the way we look at different things in our natural environment. The earth is taking a breath right now. Cars are not out there as much. We're not moving, humans aren't moving around as much. So our earth is actually taking a nice deep breath and kind of regenerating. But with that, these things are emerging in our natural environment too, like these blackberries. And when you see those blackberries and go out to pick them, you always have a choice. And we look at that. You have a choice by looking at that blackberry bush and seeing what you see a medicine there, a fruit that has medicinal properties, but you also see thorns on that bush. And so you always have that choice of looking at something, whether it's something that's medicinal and helpful, or being afraid to go in and grab some of that medicine. And we have that choice individually. But I think all those things are, when you look at things, there's always a resilient side to, or a positive side. And that's, I think, in our indigenous communities, indigenous ways, we have to embrace the resiliencies and the positivity in our communities and work together as a whole, nation to nation, tribe to tribe, and not to forget about our tribal neighbors and our non-Indigenous neighbors at the same time.
Our strengths and our connections are so critical through this. I'm reminded of what our Ojibwe colleague, Dr. Megan Bang, said. She's one of those calling for reframing social distancing to physically distant but socially connected, because that isolation, I think, has really caused a lot of stress and anxiety for folks, which is not that great in this health arena for sure. So thank you for those reminders and those stories on those fronts. And we do have some questions coming in, so keep them coming, folks. We're going to go through a few more directed questions here, and then we'll open it up. So I'm going to shift over to Ms. Chris Rhodes. Chris, it's great to see you. This is a data question. You know, I'm a bit of a data geek, so hopefully you're ready for this one, but you can always reframe. But the question is, are there any statistics available from Indian Health Services for reservation areas and or urban areas, or other Indigenous statistics, and others of you from Canada, New Zealand, other places that may know of some of the data? Folks are really curious to look at the impacts already and try to understand what's going on for our people and families and communities. Chris, do you have any insight into that?
So, Anin Boujou, I'm Chris Rhodes, and Malia, it's very nice to see you, my fellow data nerd. Well, of course, accurate health data is hard to come by for people, and the lack of data makes it difficult to focus on where to focus those limited resources. It's hard to know where the next epicenter is going to be in Indian country. Right now, it appears that it's in Navajo Nation. The IHS website is being updated on a regular basis with the number of tests that are done. But that data is really only part of the picture, because we know many tribes and urban areas do not share their data with IHS. As of April 1st, we've seen that there have been almost 5,000 people tested with around 300 positives, and more than half of those positives are in Navajo Nation. The other statistic that I saw recently is that IHS reported that across the 574 tribes, there are only 81 ventilators, 37 ICU beds across all of IHS and tribal health systems in the US. Those are some concerning numbers to me when I think about when we start seeing more of a spread.
Could I ask a question?
Thank you for that. Please do.
The specific question there is, I reached out, there's 18 reservations in San Diego County, and Dan Kalak is one of the directors of one of those clinics, and I was asking him just about testing itself. He says they have 20 test units total, and they have to restrict what they have. So are we even getting adequate numbers when we have limited testing to begin with? So what we are getting, one might argue it's probably the magnitude quite higher than what we're seeing.
Can I comment too?
Please do.
Okay, hi, it's Dorothy Rhodes. One thing just pointing out, and it follows exactly on what you just said, as even on the IHS website, by far the greatest number of tests were also done in the Navajo area. So it's not surprising that by far more cases are being detected there, but in the other areas there are, one-digit or double-digit numbers even in the testing, and for some of those areas, much less being positive. And I didn't see that there were deaths reported on that yet, but I'm pretty sure stuff is going to start coming in to let us know the scale of this. It's probably a lot worse than what we're thinking. Well, might be. I mean, the geographical distance of some places, it might take longer to reach there, but I have no doubt that it's going to get there.
And I know there are lots of purposes for testing, but from what I understand, one of the main ones is when you can identify, who is infected with this disease, you can isolate and prevent, more transmission. And that's one of the critical reasons we need more testing is one of the important pieces of this. All right, so we're going to move into some more clinical and patient-based questions. We have quite a few expert clinicians on the phone here, or on Zoom, I should say. So why don't I go to Dr. David Madison with this one. Cancer and other co-occurring conditions like diabetes are often either higher or are a disparity in Indigenous populations worldwide. What are some of the clinical preventive safeguards that patients, families, or survivors should be aware of, either in the clinic, hospital, or community? What are some of the clinical preventive safeguards? And others of you can chime in afterwards as well if you have more to add. Dr. David?
Okay, all right. Thank you. So when I think of clinical safeguards, I think of, on the one hand, doing things that would protect someone from contracting the coronavirus. On the other hand, there's also considerations for patients, based on the risk of how severe the condition will be once they, or if they actually contract the disease. So like you mentioned earlier, it is definitely, we know that patients who have comorbidities or comorbid conditions like diabetes, heart disease, lung disease, obesity definitely fare worse than those who don't. And unlike other risk factors like age and gender, those health conditions, those comorbid conditions could to some degree be modified so that if they're better controlled, and although I don't know that there's any data out there that would support this, but I would suspect that an individual with emphysema that's better controlled than not, or someone with diabetes whose glucose levels are better controlled than not, would have a better chance of doing better through an illness with COVID-19. So what I would recommend in that regard is that individuals should do everything they can to keep as healthy as they can. Like Rodney was mentioning earlier, getting outside, being active, exercising, and just enjoying nature and just having a better overall perspective, I think is one good component. In addition, maintaining a healthy diet, definitely, following your physician's recommendations with regard to medications that you should be taking, and of course, if you're a smoker, this would be a perfect time to stop smoking and to drop the habit altogether. So beyond that, there's also the safeguards clinically with regard to protecting someone from contracting the coronavirus. So some of the things that we hear all the time, social distancing, washing your hands and doing it regularly, 20 seconds. I think it's 2 cycles of the Happy Birthday song, something like that. But those are all very important. What we've done in our clinic to this end with regard to social distancing, we've been spreading out our patients' appointments so that there isn't, if we spread it out to, well, anyway, I guess that what I'm saying is that we're just having fewer patients physically in clinic at any given time because we're spreading the appointments out. So there's an easier opportunity for them to maintain the 6 feet separation minimum and to, I guess, meet the social distancing recommendations. We've also, with regard to our in-clinic visits, like for consultations and for follow-ups, we've been trying to move as many of those as possible to virtual visits. So we try and do teleconferencing or like FaceTime if possible. And in many cases we can. If we can't, for whatever reason, if the patient doesn't have the technology or if they don't have the internet access for one reason or another, then we do, you know, a phone visit, which is still adequate, and we can get a lot of good information out of that, though it's not as good as teleconferencing. So, you know, in Hawaii, as an example, there's more Hawaiians in rural communities, or Hawaiians represent a greater proportion of the population in rural communities than they do in urban communities. And this may present a challenge for, you know, for Native Hawaiians in Hawaii. And, you know, this, you know, by extension, could be, you know, a similar challenge for other indigenous cultures throughout the United States. So that's, you know, those are some considerations with regard to social distancing, what we've done, some of the existing challenges, and of course, like many other indigenous cultures, Native Hawaiians are, you know, there's a communal component to our culture. There's a multi-generational households where there's grandparents, and then, you know, the parents and then the children all living together. And that's actually how I grew up in Hawaii, and how many of my friends and extended family have grown up also. That presents an additional layer of challenges with regard to social distancing that I think, you know, should definitely be evaluated at the very least, to, you know, to try and reduce the risk to of exposure, particularly to the more vulnerable, you know, part of the population, which would be our kapuna, or our elders.
Thank you. So those ideas of kind of the systems available, you know, clinical systems in rural communities, the cultural ways of living and moving, you know, all play into the comorbidities as well, and trying to have a healthy lifestyle in order to face this should it come upon you and your family. Really are important safeguards for sure that practitioners are thinking about as well. All right, we might head to Dr. Amanda Brugel. I know she was kind of coming and going. Is she off?
There's a couple points I wanted to add to David's, if that's okay.
Please, definitely.
Okay, I guess I should introduce myself. I'm Patrick Linson. I'm both Navajo and Pueblo from northern New Mexico. Like David, I am a radiation oncologist. And I've been practicing now in San Diego for the last close to 20 years. Prior to that, though, I'd actually worked in the HIV and AIDS world, and particularly in Native communities. I was working at the American Indian Health Center in San Diego. And it's a lot of parallels to what I'm seeing now. There was a lot of stigma, more stigma, I should say, associated with HIV and AIDS. And many of the challenges were similar, though. And so it kind of awakens me to what we were facing then, and the fact that we got through it then, and the likelihood we'll get through this again, and partly because of the people like you that are out there. As a radiation oncologist, I specialize in the treatment of brain, lung, and prostate cancers. And for my patients, we've been trying to prioritize who needs treatment. And David's already pointed out, I think, most of the key areas that we're trying to acknowledge for our patients, but I think there are a few others, and part of it is educating our patients. You know, he's mentioned the hand washing, the social distancing, which in many of our communities, it's not as easy when you have multi-generational families living together and in a small area. But the importance of identifying people who might be sick early, and whether it's the cough, or the shortness of breath, or fever, so those patients can be isolated and or treated more readily and protect the rest of the family. Also, we need to educate the patients around the fact that what we're trying to do now with radiation is if patients don't necessarily need treatment. So in early stage prostate cancer, for example, you can wait 6 months or 8 months without interfering your ability to cure the patient. Or an early stage breast cancer, or DCIS, where they can be put on medication, tamoxifen, or hormone receptor antagonists to hold them off before the need for treatment and not putting them at risk. David already mentioned a very good thing where we stagger the patients. But even for ourselves as staff, we're trying to stagger ourselves. So we're trying to limit our activity within the clinic. So telemedicine for the patients so they can be at home getting their care. And then for us as doctors, if one of us or our group of us get sick at the same time, we'll have staff that can step in. Now working at an urban Indian clinic, oftentimes we're already limited with staff, we're already limited with what we have for PPE. But the idea is to be prepared, knowing in the next week or two, we're gonna need even more of this, and alerting the powers that be to try to get that equipment for us so we can better take care of our patients and protect them. It's important, I think, that we talk to our patients, and there's some really good educational ways of doing this, not so much protecting them, but protecting our elders, because if we're doing these things, it's helping them, and sometimes taking the focus, sometimes the way we think isn't so much about ourselves, but about our elders. And if you turn that focus that way, I think people are more inclined. I saw some really good public health work that was being done, and I want to get her name right. And I've seen it, her Vanessa Bowen with Native Realities. I've seen a lot of her stuff coming out and talking about protecting the elders, and maybe disseminating more information like that so our Native communities can see that and know why it's important from a Native perspective. There's as providers, so in addition to limiting the number of people coming into the clinic, we're having our patients wait in their car, and we can tell them, you know, when they're ready for their treatment, come in now, so not everybody's waiting in the waiting room together. Consider a short course. So for the last 12 years, I specialized in the treatment of what we call stereotactic radiosurgery. And David, I'm sure, is doing this as well, where you can do treatments in a single treatment or 5 treatments. But the idea is to treat a prostate cancer patient over a short time, so risk limiting their exposure. Sometimes patients might be thinking they're getting gypped out or cheated out of their course of treatment, when we're telling them, by doing it this way, your chance of cure is still high, but we're trying to, and so it's a form of educating the patient where, well, my cousin got 8 weeks of treatment, why am I only getting 1? And so it's actually having to educate the patients in that way. We talked about for breast cancer, putting patients on tamoxifen. For prostate cancer, we can put them on hormonal therapy. In many instances, it's part of their care, but it will help stretch out, you know, maybe 3 or 4 months from when we need to treat them. Early stage skin cancers, which we all treat as well, those don't necessarily need to be treated right away. It's trying to get that education out there. Now, for our staff, it's important we keep them healthy so they can take care of our patients. So the idea is treating our elderly patients, the patients with diabetes, the patients with heart disease, the ones that we've identified as being the highest risk of running into trouble. We want to treat those patients in the morning. And then I treat patients who come in from the prisons and the penitentiary system. We're starting to see reports of high rates of disease there, and many of those patients aren't getting treated either. We'll treat those ones in the afternoon. That way, if there is a risk of infection, we can clean the center and get everything ready for the next day. We try to, like I say, work in skeleton crews so that if we do get sick, we have another crew that can come in and take over. And then limiting exam rooms. So if I'm working in one room and my colleague's working in the other, and if we're just switching forth and the stethoscopes are going back and forth, if one of us is sick, there's a higher likelihood we'll get each other sick and get the patient sick. So we're trying to limit ourselves to an exam room each, so that way, and it's not always ideal, but that way our nurses work with us in just the one room, and once again, trying to limit and physically distance ourselves from each other and help the patients to prevent infection. And once again, as best we can, take care of the patients, and the best way we can, let them know that we're doing things what's best for them. Raises this whole issue of masks and the need for masks. And we went from not even doctors and nurses wearing masks to now the feeling is everybody should probably be wearing a mask, and why that's important. Once again, not having resources in the PPE, even for the doctors, much less to give to the patients. I've been fighting with the administration and my center to be able to provide it to our patients. Once again, with the education, and there's a limited amount of resources. I have my daughter sewing masks at home and my wife sewing masks at home now. And I got a call from ABC News about my daughter. She's been interviewed like 3 times this week already about what she's doing. And it's a heartwarming story, because now I've got people bringing masks to work, and I got people around the country asking me, you know, how she's doing it and encouraging them to make masks. And my son making face shields now, and the kid down the street is making hand sanitizers. So, you know, incorporating, you know, before I was a doctor, I worked in HIV and AIDS, and the idea was, I worked with a youth program then, was teaching the kids, you could save lives now by educating, by doing the right thing. And you don't need to be a doctor or a nurse or a health professional to do that. And so I think education is going to be really important in our community, getting a very, very positive messages out. And what Rodney was talking about, you know, we can still keep our culture and still do the right thing for this disease to try to limit and prevent further spread that we know is going to come. And then also, even back then in the HIV and AIDS world, our Native people were dying at a much higher rate, being infected at a much higher rate. And some of it was explainable, some of it wasn't. You know, we know that respiratory illness predominantly affects Native people at a much higher rate and with a much higher rate of morbidity. And so it's gonna hit our communities hard, and we have to be prepared for it, knowing that whether it's TB or respiratory syncytial virus or hantavirus or all the, you name it, you know, sometimes 5 and 10-fold higher rates, we have to only expect that this is gonna be higher too. And so for raising this as a level of urgency, Rodney, is very appreciated, because I think we all know what's coming in the next few weeks to our communities, and what we can do to help is we need to be there.
Thank you for those comments, Dr. Patrick. I really appreciate that. You know, you raised too an issue of shift change and kind of the impact of labor workforce, and, you know, all of our worries about you all as providers getting ill. So I think those, and how communities can be enlisted in assisting with PPE, really critical pieces that we're starting to see unfold in many different places, struggling with infrastructure and resources. Okay, we've seen some of the reports in some countries that we're seeing higher rates of men dying from this disease. And so I wanted to ask first Dr. Amanda Brugel, but certainly open it up to others, if from a clinical stance, are there any specific gender issues to be aware of in response to COVID-19, cancer, Indigenous context in that sense? Not just, you know, men, you're obviously a clinical or gynecological oncologist, so thinking about them. I'm sitting here in Seattle, 9 months pregnant myself, certainly have some concerns from a gender-related stance, but just some of your thoughts around specific gender issues to be aware of in this pandemic.
So from a gender perspective, there aren't different national recommendations on how to approach prevention. It's the same: hand wash, physical distancing, avoiding sick contacts, same rules for both genders. This is a unique situation where we don't have years of data behind us. It's sort of emerging over time. We see publications from Wuhan and Italy coming out, and we're seeing that there's a slightly higher rate and certainly more severe disease among men, but that does not by any means mean that women are immune or women should be the caretakers of sick people. It's a very small difference, like 1 to 3%, depending on the studies. You know, there's some kind of fun science nerdery looking about why that might be. Women tend to have more robust immune systems. And that's why you also see more immune disorders among women than men. So like things like RA and lupus tend to affect women. But that doesn't mean that we are better at fighting the disease and curing it at this time, or that we need different recommendations based on gender. In terms of pregnancy things, the last time I delivered a baby was about 15 years ago, so I am not the obstetrical expert, but being part of an OBGYN department, I can say that for pregnant women, the outcomes of women in the 3rd trimester seem to be okay. There is some data that the virus crosses the placenta, but they aren't seeing poor neonatal outcomes. With any respiratory disease for pregnant women, there's an increased respiratory demand. And so diseases like influenza and other respiratory viruses can increase your risk for severe outcomes, needing a ventilator, things like that. We have really, really limited data on 1st and 2nd trimester. And recommendations right now for pregnant women are to hand hygiene, avoid sick people, you know, kind of all the classic good information we're hearing. And regarding some of the face mask discussion that we've been having, the CDC, I actually just got a push notification on my phone. They are recommending masks for everyone. So cloth masks when you're out and about is now being endorsed by the CDC. Our government leadership says that this is voluntary, but if we're looking at the leading health recommenders in our country right now, they are saying cloth masks do make sense for people.
Great, thank you for that. Others want to comment on any specific gender-related issues that you're seeing or concerned about?
Well, this is Dory talking, and I guess I should probably formally introduce myself. So I'll say Deonde Bakale Tan Dorothy or Dory Rhodes Alcon Doyama Algoikan. I'm saying it's good that we've come together. I've already introduced my name before, Dorothy Rhodes, and my Kiowa name is Medicine Woman. Forgive me, anybody who's in the audience, if I have mispronounced the Kiowa language. I want to thank Rodney and you, Malia, for moderating this and bringing it together. I am a clinician. I'm a clinical associate professor at the University of Oklahoma Health Sciences Center and epidemiologist with the Cancer Health Disparities Program at Stevenson Cancer Center. Just a couple of things about the gender differences. Initially in the countries such as Italy and Wuhan, the higher predominance of men was thought to be related to the higher prevalence of smoking among men in those populations. And that did not reassure me because, as many of you probably already know, and for a lot of our smoking indigenous communities, there's no significant difference between the rates of smoking between men and women. There's a surprising lack of research on chronic lung disease among American Indian people. One of my colleagues here at the Health Sciences Center is trying to look at things like chronic obstructive pulmonary disease and if there might be any differences, particularly in American Indian populations, because there's, surprisingly, there's not a whole lot of literature on that. And that's one area that I think would be really good for us to look at. So that's just one input that I had on in terms of the gender issues.
Very helpful. Thank you for pointing that out. I do remember seeing that now, those rates there.
With regards to pregnancy, we are really pushing flu vaccination for pregnant women. And we've got vans going out to communities with, high rates of poverty, high Māori populations, and providing free flu vaccinations. So for our pregnant women and for anybody over this age of 65, and also anybody with a long-term condition, our tribes or our iwi who have been traditionally providers of health services. So health services are provided through health organisations, but our iwi have registers of their tribal members, and they have been calling their members and arranging for them to get the flu vaccination. And also we've been working the health organisation I work with is working with our tribes to provide vans, free vaccine, and nurses to go out and immunise people, and also do a health needs assessment for long-term conditions. And we're just working on how to get something, maybe even just FaceTime, so we can have instant access to clinicians whilst they're out on the road.
Telemedicine is helping in a lot of communities, I know, so that's great to point out what the efforts are there. It's so needed, and we know that about remote and rural communities, just the infrastructure needs that we have. So, all right, we've got two more kind of structured questions before we open it up, so please do send through. We have quite a list of questions from the participants, so please keep those coming. Let's see, I'll just open this up. If there is one message that was most important to share to our Indigenous communities about COVID-19 and the cancer care continuum, for example, patients or survivors, what would it be? One message that was important to share to our Indigenous communities about COVID-19 and cancer care. What would that be? Who would like to start?
I can start. So one thing that that I think is important to bear in mind, and something that's relevant to COVID-19, but also really as a general rule is, and again going back to my culture, Native Hawaiians, as an island people, we're raised to respect anything that we see as authority, and it can be, a benefit, but it could also be a detriment. As an example, online information, for example, has really transformed our culture in a lot of ways for better, but also for worse. An example of a benefit is that when there's credible online information or credible information that we can use to better our lives or what we do, then that's a good thing. But when there's less credible information that we're not as able to discern. And for instance, although I haven't seen any with regard to the Native Hawaiian community, but I did come across an article talking about of supposed treatment, prevention, and cure for the coronavirus that involved drinking herbal teas. Now, if someone were to do that, believe in that and do that, and not be as careful with hand washing or social distancing, they could certainly put themselves at risk, because there's no evidence to support herbal teas protecting against the coronavirus or treating it out. So that's one thing that I think would be important, for us to bear in mind going forward, and to reinforce with our patients that if they have any questions coming through about, is this something that may help? Should I do this? It may not hurt, but it certainly shouldn't be a replacement for social distancing and good hygiene.
Being conscious of where the information is coming from. Thank you for that.
If it's all right, I had some other ideas as well. And one that kind of struck me was, as a people, as Indigenous people, we know what smallpox did to our communities. Some did not recover, they're gone because of smallpox, and others, we have lived through it. We have the opportunity now, as we learn how to protect ourselves, we protect others, and as we protect others, we protect ourselves. That's one of the big bottom lines. And one thing we can do for right now, and it's just critically important, that cancer patients avoid being exposed to this virus, and that any one of us here on the panel right now could be infected and not know it, because the first few days can be asymptomatic, and people we can come in contact with could get it from us. So that's just one thing, that everything that can be done to minimize exposures as possible, and identifying a person who leaves the household to get the goods to bring back to the house, whether it's multi-generation or other, to protect that unit, I think are just critically important. Taking advantage of what I'll call the new smoke signal, the virtual communications, that you can have distance communication and support, and nothing like a virtual drum group to help raise the spirits without having to expose those singers and those drummers to exposures by coming together around a drum. That will happen for us at some time. We just need to do everything we can now to make sure that we get to that point, get past this, and work that way. Some other thoughts are, I just kind of point out the American Cancer Society has an excellent website, I think, right up front, in terms of information for patients, information for their caregivers, all those signs, the 100.4 fever, the cough, the chest tightness, the alarm symptoms for like, okay, this isn't a call to your doctor, this is get to the hospital. I think those are all wonderful things that people should avail themselves of. Our nasal passages and our lungs are as susceptible to this as anybody else's is. So taking advantage of these sources of excellent information and ways to protect are good. One thing that I tried to clarify, like, well, what about these clinical trials, such as the immunomodulators? People are looking at the hydroxychloroquine. Our president is, touting this wonderful, treatment. There are clinical trials that are in progress. Some of them for active treatment will exclude cancer patients. There are some that I've seen on clinicaltrials.gov that show that there's like some preventive research trials that are in progress, and you're not necessarily excluded if you've had a previous history of cancer. So our own institution is going to have some the quick clinical trials in the hospital patients, but also for patients with cancer who are undergoing current treatment right now. That letter that I think that was spoken of is true here as well. The prioritizing, the risks of the benefits, the risks of getting the treatment you need now because your cancer will put you at a high risk of death. Is that risk higher than your exposure from going in? Those are getting prioritized. And our cancer center, at least, is asking people with those kinds of conditions not to reduce their treatment that they're undergoing. That is also true for clinical trials that are cancer clinical trials. If this is something that's very high risk cancer, it's obviously a case-by-case basis, but I would hate for people who need their prolonging life-saving treatment to not get it, and it's a risk-benefit kind of concern. So I'm trying to shove in a lot of thoughts that I had as preparing for this, but I was actually impressed with that particular website, the American Cancer Society, which is what, cancer.org, I think? Yeah, okay. And I'll let others have a chance to comment. Thank you.
I'll just chime in real quick too. And it's like there's always this blend between like indigenous ways of knowing and also Western perspectives, right? So like even with our like clinical trials, you mentioned clinical trials that in some cases, some of the clinical trials have to go on hiatus because of being in the laboratory or going in sequence in a basic type science. But in other cases, like prevention and our community-based participatory research, there's still an ability to participate if you are in clinical trials from a virtual standpoint. So the protocols are changing. We're evolving by being more virtual in our ways to work with patients, but our clinical trials and research too are becoming more virtual in the way that we still continue talking about cancer and the issues around that with our communities, in a virtual sense now. From a traditional sense too, I find that one thing that, the message that I would say is to, I started out with the same way, is that to reconnect with our ways, here's a time, here's a break from our hustle and bustle of going out every day and doing the things that we're doing to really, re-explore or reconnect with some of the things. And that includes, I talked about some of our ancestral activities, but just getting outside and walking, and maybe listening to some of our songs, our old songs, and those songs have been with us before, since the beginning of creation. Maybe even before that time, those songs have been with us. And how do we reconnect with that? And what does that mean to us? Sing yourself a song. Sing a song for your children. You don't have to be the best singer in the world, but it means something to them. It means something to yourself. Dance if you're a dancer. Dance for your family, dance for your community, dance for yourself. You don't have to be a competition dancer. You can shuffle around and feel good about it. It's about how you set your mind and your framework to really think about, bringing that, what we call the good mind into things. And that once you bring that into yourself, that kind of emanates to others in our families and our communities. And when we all do that together, then that brings, more of a mental wellness and well-being to ourselves. So, those are things that we can do every day. Our, in a Haudenosaunee, we have the Ganonyo, which gives thanks. And many indigenous cultures have that. Say that with your children. Say that with your elders. Say that with the family. So I just want to put that in there. It's like, we have this clinical thing. We talk about, cancer in a clinical type way too, and working in Western clinical settings. But we ourselves some of our greatest healers are in our communities. And we have to listen to some of those old stories. We ourselves know ourselves the best. We've been through this, as it was mentioned. We've been through pandemics before, many, many decades ago, hundreds of years ago, but we're still here. We're still resilient and we're still thriving.
I want to add a little bit to that. I love what you just had to say, Rodney. I'm going to put my Master's of Public Health hat on now. And taking it on a practical level, if there was one message I wanted to get to my cancer patients, to our cancer patients, is that cancer treatment's important and we cannot forget about it. And that I talked about a couple instances where we can put it aside or delay it, but our patients can't delay it. The high rates of morbidity or mortality of them dying from their cancer in many instances can be much higher than the risk of them getting this virus and dying from it. So we still have to get that message out that they need their treatment. And regardless of the challenges that they face, it's important that they get treatment. We got to get that message out to our Native people that they cannot, stop or halt or delay what could be a life-threatening cancer for a virus that may hurt them or may not. For all of our people, and as it relates to cancer, I think that the strong message has to be social distancing. And I think the strong message has to be hand washing. And I love putting a perspective on it that's cultural and Native. And so whether it's to protect our elders or to protect our families, the idea that we all don't necessarily live as individuals, but we're here as a community, and we're not doing it for ourselves, we're doing it for others. And if we can frame it that way, I think our communities will listen and will hopefully try to prevent further spread. So those with cancer get treatment, and those who don't, or who might be at risk for the virus, try to keep safe.
We've got, so our group has developed just a really simple picture chart for Māori patients with cancer. And I could share the screen, but I'll share the link with you, Malia. And it's of all of these key messages, keep in touch with your cancer team. The bubble within a bubble concept for families who are living in multi-generational households. We've started to think about what do you do if you've got somebody with cancer and then a positive case living in the same house, and we're developing solutions. So some of our tribes own hotels, and so and also our traditional marae meeting houses. So talking about putting people who are positive but can't stay safely at home into alternative accommodation.
Beautiful. And that kind of takes us to our last question for the panels before we go to the open-ended ones, which are, what are some of the ways Indigenous communities are effectively addressing this pandemic? What does this look like? It's early days for some communities, but we know there are some promising practices and great examples out there. So anybody have a few to share with us and inspire us?
I've been really inspired to see the innovations coming from Indian country. The social distancing powwow has been huge, and the jingle dress dancers sharing healing videos, seeing ceremonies being modified so that we continue to have our ceremonies in our traditional ways to stay connected. Not only has the social distancing powwow happened, but I've seen our Native comedians come together with events to keep us all uplifted, our musicians. It's been really beautiful to be able to stay home and still stay connected in these ways. Again, the Native seamstresses that are out there making all of these beautiful masks that are way better than anybody else with the beautiful Native additions to them. They really are amazing. And we've seen our Native chefs step up and feeding our elders in amazing ways. At the American Indian Cancer Foundation, we're hosting a virtual Powwow for Hope this summer, which is about honoring cancer survivors. And we have virtual support groups for Native cancer survivors, patients, and caregivers. So hopefully those will be useful to folks as well.
Hi7.
We can hear you.
Great. I was just going to say that dozens of our communities in our province have actually gone into lockdown. They've closed their borders to visitors and to tourists. I know that other First Nations in Canada as well, like close to the Arctic Circle, have closed. One of our enormous island groups, Haida Gwaii, has closed themselves off from visitors and tourists, and that's been somewhat effective, and it's been really interesting because that's a self-determination political step much more so than an interaction with the medical system. Just wanted to acknowledge that.
We've had in Aotearoa, New Zealand, we've had communities closing themselves off too, with guards at the road, checkpoints and stuff to let people in, and really great, you know, internet-based cultural activities, language lessons, you know, cultural performances. And so that has been very good. We've had a lot of call centres opening up where people are calling their well, we're starting, I've got a call centre in my team as well, and we're starting off with our priority groups, so our older kaumātua, and people who have our long-term conditions, and we've developed up an assessment tool, a screening tool. It's electronic, it feeds into a database and links with all of the services that we know of that are out there. So, and our callers are trained, and when they find out what the elders need or the families need, and then arrange for those needs to be met. And then when they're not able to meet those needs, we have a meeting every day where we problem solve with other call centres. So we've invited tribes in who have got call centres, and we problem solve together. And so we're arranging for, you know, food and medication and heaters. It's winter now. Warm clothes, personal continence products for people who need them. Nurses to go out and do flu vaccinations for when the elders can't make it to the mobile vans or the other centres. Now we're trying to link up directly with our virtual clinicians. So just getting that process all sorted out.
So in Hawaii, our Office of Hawaiian Affairs has done things, including putting together an information packet for the Native community. And it's really for everyone, but outlining the scope of the problem and how it relates to the Native Hawaiian community. They list the comorbid conditions, and indicate how much more prevalent it is in the Native Hawaiian communities compared to the non-Native Hawaiian community. And in addition, in each section, they also provide resources and references for individuals who would be, looking for help or for additional information with regard to those points. And those packets are made available to the community. In addition, OHA, together with leaders throughout the community, have been getting together. Leaders including, representatives from education, from the healthcare sector, even from their Washington representation, have been getting together to identify needs that they see within the Native Hawaiian community in the context of the broader community. Interestingly, and just kind of anecdotally, Hawaii's, I think there's about maybe about 400 cases of coronavirus, if I'm not mistaken, at this point. There's only been 2 deaths to this point. So the epidemic really hasn't hit there very hard, but some of the important points that were raised included the healthcare available in rural areas and the availability of PPEs in those clinics. Now, certainly, even in the big city of Honolulu, ICUs and hospitals have been overwhelmed to this point with people with coronavirus. But with the anticipated surge that we may see in the coming weeks, it could be a concern. So one of the issues that was raised was the availability of healthcare and the importance of having a contingency plan for patients in rural communities should the need outweigh the resources there, and how they'll get those patients to, from different island, neighbor islands, to Honolulu on Oahu in order to get the care that they need. So those things came up, and again, just as a side note, interestingly, the economic impact of things came up at several points, including childcare and health insurance even, and possibly losing health insurance when people are losing their jobs, and a lot of jobs are lost because the tourism and the service industry is a big part of the economy, and maybe 20% or more of Native Hawaiians are actually employed within the tourism and service industry. So that's a huge I guess potential for for problems there if the economy is the collateral effect of the coronavirus takes hold there.
This is Dory Rhodes talking about here nationwide. The National Indian Health Board has tried to step up and have a nice also web page, and also in collaboration with the Association of American Indian Physicians. Our current president, Dr. Walt Hollow, has actually it's come up. In preparation for this, I looked a few days ago, and this wasn't up by then, but it's as of March 31st. He has on the NIHB.org site, there is a link that says AAIP Partner Blog, and he has the role of nice one-page.
Dory, are you there? You're frozen on my screen. Okay. We'll hopefully try to come back to Dory. Are you folks hearing her, or is she frozen on your screen as well? Okay.
Just on the
take this?
Okay.
side,
There she is.
Okay.
Go ahead. Sorry. We lost you there for a second, Dr. Dory.
Oh, I thought maybe I was just going on for a little too long. No, it was my Wi-Fi. I'm out here in the beautiful Wichita Mountains. I was trying to set up a nice picture where you could get a picture of our Cope Adel, our big mountain, also known as Mount Scott out here, but it didn't work. And sometimes my connections go in and out. But did you hear that? Did you heard about Walt Hollow's essay at the NIHB site? Okay, very good.
I was going to
Dr.
add
Patrick, were you trying to?
Yeah, just a little bit of a story. Our president, Dr. Jonathan Nez from Navajo Nation, has been working well with the New Mexico governor, Grisham, and raising the awareness of this problem, at least to our government. And our Navajo Nation, what they did was they enacted back in the second week of March, very tight restrictions, and all the way down to limiting and curfew from 8 p.m. to 5 in the morning to try to limit any kind of, and basically help with the social distancing problem. But on the positive end of having testing and having the Navajo Nation having the testing that it did, it raised the awareness that this is going to be a big problem. And as a result, some of the stimulus packages have translated into $1 billion for IHS, and then an additional $8 billion for Indian communities as a relief fund. As all of us know, we already have limited resources within our community for doing what we need to do for our patients now. So my hope is some of this will be helpful. And I know it's sad, this is how you have to get it, but the reality is at least some of these resources now can be directed towards COVID and towards the health of our people.
Thank you so much. All right, we're going to shift to some of the questions that have come in. I apologize if we're not able to get to all of them, but we will do our best here. We had one come in from an Aboriginal nurse, Odette Best, who I've certainly read about some of your cultural safety work. She says, in Australia, our remote Indigenous communities have been locked down. We talked a little bit about this in Canada. I know this is the case in Alaska. No one in, no one out. Is this happening elsewhere? And if so, do you think this may trigger PTSD for Indigenous peoples, again, who under legislation could not move off our missions and reserves a mere 30 years ago? She's an Aboriginal nurse in Australia named Odette Best.
Hi, it's Evan. Certainly where we are, I have public health authority to restrict movement and to force people into isolation, but we're not doing that because we need to be very balanced in our approach to Indigenous clients. We know that they can have traumatic histories and that breaking their heads because they've been truant about staying inside may not be viewed very nicely, even though some part of the First Nations community is getting pretty angry, saying, I saw so-and-so walking around and I know they shouldn't be. So we're taking a very balanced educational approach and speaking to people and saying, well, let me explain again why you need to self-isolate. And we do have powers, and we probably eventually will get to using harsher measures, but it can look bad on us, and it can, and I think some of our Indigenous social shaming can work wonders given a chance.
Thank you. We had a question too that I've certainly seen online. Elderberry is a traditional medicine that many people use. I have heard that it can make COVID-19 symptoms worse. Have you heard this? Do you have any evidence that you know of? This is someone who is anonymous. No thoughts on that one. We'll shift to another here. Let's see.
I'll just add, sorry, I just spoke, but I will add that in our meeting with Indigenous people on a cancer journey, the vast majority of them were using traditional medicines. I would say upwards of 98% of them. We were absolutely surprised how many were using traditional medicine. And we recognized that most of the people that they were encountering were not traditional people. They were not people who had knowledge of those medicines, and that sometimes those Western-trained caregivers would warn them that mixing traditional medicine and their modern cancer medicines may not be a good idea. So we would say that forcing an Indigenous person to put down traditional medicine maybe isn't a way to go, and isn't there a way for them to have both types of medicine?
Well, while you're up, Dr. Adams, we have one specific for you and Dr. Bruegel from Brett Benally Thompson. He says, please comment on how we explain the importance of social distancing and explaining this disease to our elders and other community members through both traditional and modern scientific views. And he says, miigwech.
Stay one moose away. Or if you're from the south, stay 6 dogs away.
I think, the conversation about, and I like how somebody said physical distancing instead of social distancing before. I think that's a really important shift, and I'm liking that. I think there's different ways to say it and how people need to hear it. I think if you're giving someone an order and you say, you must physically distance, that sounds punitive and like punishment. And I think if we can use language that's empowering, like you can protect your family members, your community, this is how you can be part of a solution. I think using language that empowers us rather than makes us feel like powerless can be really helpful as a way to reframe a conversation in a different way. I think many cultures, not just Indigenous cultures, are being asked to modify traditional customs. We know that the Vatican has canceled Easter, which is a really big thing for Christian religion. Or not canceled Easter, but essentially like big church and masses and things. And practitioners of Islam are not coming together on prayer mats together and are being asked to modify in this short time. And I think if we can respectfully ask our community members, how can we adapt but still do our traditional practices and be a part of that community and culture? I think that's the best way to sort of empower us to sort of temporarily adhere to what these guidelines are.
It's great. Actually, I'd like to add something too. I think someone mentioned this earlier in the conversation, that it's really also about protecting those around us, because social distancing, while it may prevent us from getting the coronavirus, it actually can prevent us from being a vector and transferring it onto other people. And I think, by and large, most everyone in the United States is not known to have it. But I think that if we all acted and carried on as if we did, and by maintaining a social distance or a physical distance from others, washing our hands so that we don't pass whatever we might have onto other people, for the benefit of them, for the benefit of our friends, colleagues, our loved ones, our kupuna, that I think is an empowering message and compelling, and that may be a way of convincing people to really take this seriously.
David, we have I think I'm getting this right, 3 messages. Be kind, stay home, save lives. That's our kind of. I went for a walk around my neighborhood the other day, because we're still allowed to go for local walks, as long as you're 2 meters away from people. Like if I'm walking down the street and somebody else is walking towards me, one of us has to cross the street. And I saw that message written by a little girl, had written it on the pavement in chalk. But it's gaining. Everybody knows that here. Quite good.
Yeah, we're
education.
In British Columbia. We're changing the stay home message to that your home includes your traditional territories, not just the 4 walls that you live in. We are encouraging people to go onto the land and be on the land as long as they keep their physical distance from each other. So yes to physical distancing, and yes to distance socializing, which is an adjustment. And we're saying spread the love, not the virus.
Love that. Love that. All right. Well, Pete Hill asks, are there complications or harmful interactions with mainstream medicine and our traditional medicines? Is there a way to avoid those harmful interactions? He says he has high blood pressure, cholesterol, prostate issues, and other conditions, and he would appreciate any guidance. Any complications or interactions between mainstream and traditional medicines?
I can't speak to traditional medicines, but some traditional medicines, for example, are antioxidants, and pretty strong antioxidants. And radiation works by oxidative damage to DNA, and that DNA that's damaged ultimately results in the death of the cancer cell. And so we have to be careful sometimes with what people are doing, both over-the-counter stuff, stuff that they get from their friends, as well as what could be traditional. I think generally what's been in communities, in our native communities for a long time, is deemed pretty safe. And most of what you get from the earth is deemed, at least that's been in our cultures for sometimes, is very safe. So I'm not so worried when I see my patients bringing in traditional stuff. It's when they're bringing in stuff off the counter, things that have high antioxidants that I know might interfere with their care. So in general, I don't get as alerted as much as a radiation oncologist knowing that. Now, if I'm ever uncertain, I'll sometimes tell patients maybe not to do it during their days of their getting treatment or active treatment. And oftentimes you can look this stuff up, and there are resources that help with both alternative and complementary medicines that can be helpful to the patient. The last thing we want to do is stop that. But there are times where we do have to be very cautious and concerned.
And I'd like to add, so there are are other examples of, say, herbal remedies, or even herbs that you can get from the store that are purported to boost the immune system. That's a good thing, generally speaking. But if you've got autoimmune disease, that could be problematic for you, like lupus, for instance. I think a great approach to this would be, if your physician recommends a medication, just mention any kind of herbal remedy or complementary form of medicine that you intend to take at the same time, and that your physician should be able to let you know whether that's safe to do together, or whether it wouldn't be advised. And that would definitely be the best source, rather than trying to look up the answer on the internet.
One additional resource for providers, Memorial Sloan Kettering has a natural medicine link. You can essentially Google it and find it. And I've used this with many of my patients who, both Indigenous and other cultures, will have traditional medicines they want to keep. And I will use that as a resource to check things. And with my Indigenous patients, I will also ask if it's okay if I talk to their traditional spiritual person, so that we can talk about things together and figure out what's a way to find a happy medium. So I think there's a few things that are, can be harmful, but I think there's many things that we can blend together safely for our patients.
All right, last question before we move to Dr. Rodney to close us out. There's been a lot of conversations about food deserts and access to healthy foods over many years in our communities, but certainly now, this is from William Mabey, being that individuals experiencing persistent disease states such as cancer are at higher risk for nutritional deficiency, is there an emphasis on ensuring our Indigenous cancer patients are adequately nourished as a logical mitigation strategy for not just COVID-19, but other opportunistic infections, nutritional deficiencies?
That is a terrific question. It's just a terrific question. And I know, I don't know about all tribes, but certainly our tribe does have elder programs for feeding. But I think that's a wonderful question that deserves further exploration. If there's something in addition that we could do to ensure the nutritional status of our cancer patients. And you're right, it's good for just about anybody.
I think that, and it's multi-leveled as well. So first of all, we are already having people who, when we call them up on the phone, they don't have enough food, so let alone high quality food. And so we're developing solutions, and we've just recently got a Civil Defence 0800 number where people can ring and get food delivered. So we've resolved the food. Fresh fruit and vegetables are an issue as well. So talking about food quality, and I'm hoping that the solutions that we're developing now will be transferable to the new world, because food poverty has been an issue for a long time, and I'm hoping the COVID agile solutions that we're developing now will be will survive in the new world. And we're developing so many around the world, I imagine, agile, novel solutions that work for people.
Absolutely.
We
Absolutely.
don't. Hi7 again. As I said before, we are encouraging people to go out on the land to hunt and to fish. And of course, here in the Northern Hemisphere, it's spring. So we're just, starting the growing season, and we're reminding communities, and luckily for years, we've been helping communities create community gardens, we're saying to them, you know, now is the time, because part of the after effect or part of the effects of COVID will be poverty. People will need to have some protections against, you know, food deserts. So we're really cheering them on, and I'm not sure if we're actually going to be helping with those gardens, but we're telling them, yeah, you have to do that work. We really like for you to do that work.
Absolutely. Critical. All right. Well, thank you all for contributing and all the participants. I'm sorry we didn't get to everybody's questions, but several put resources up in the links. And so I do hope this is going to be, the link will be sent out. But before we close formally, we're going to go back to Dr. Rodney, our illustrious host, and he would like to share a closeout story with us. So Dr. Rodney.
Well, thank you. I want to just kind of focus on Nina's picture here in the corner, and it wouldn't be a fireside chat without a fire. So I appreciate you bringing that fire to us from New Zealand. It's winter there, or coming into winter, so I know it's kind of brisk out. So appreciate that. But I just want to share a story from our area, and it wouldn't be a fireside chat without an actual story. And so hopefully I do justice, Dr. Adams and Thomas builds a fire to the storytelling that I'll share. So, but this story comes to us, and as you think about this story, I want you to think about that fire that's there, and you know, these multiple fires that we have in our communities, whether it be on the beaches of Hawaii or Aotearoa, or the beaches or the sands of the Southwest, or the fire that we keep in our hills here in the Haudenosaunee territories. That each one of our communities has a fire, and we share and we tell stories. And that's part of our healing too, is to tell those stories, those old stories, those new stories, all the stories that we have. And so the one I'm going to share today is about, again, I mentioned a lot of our medicine in our communities, at least for the men, come around this game of lacrosse. And many of our tribes and iwis have different types of ancestral games that we play. Many tribes have variations of stick games. And so this one talks about some of the, and as I mentioned, you know, think about, you know, the storytelling in our communities around these fires. But vision, in our old games, we talk about the game of lacrosse and the game of medicine, the medicine game. And it's not only just the players that are playing and bringing their athleticism, their mind, body, and soul into these games, but it's a game that's played for our elders and for our youth that are watching, and it provides a medicine for when they watch. It's a game that we play ourselves, and as we run about and we're healthy, it's also that we play for those that can't play anymore. And all these things are combined into this game. It's a game that we play for our creator, and it's a game that kind of ties our communities together. So it's a greater form of medicine that we have among our community. But the very first lacrosse game that was said to have been played in the Sky World, or I've heard other versions that it was played here on Earth. But in this game, there was the first game that was played was a game between the animals and the birds, the four-legged animals and the winged birds. And all the creatures wanted to play, right? Because it was the first game, was a very important game. And this game has a lot of symbolism too, between a good mind and the not so good mind, and all these interplays that we have in our communities. And it ties into what we're going through now too. It goes through resiliencies and some of the things that are challenging, and how do we be resilient in our communities. But this first game, everybody wanted to play. So the animals were gathering on one side, the four-legged animals, and the birds were gathering on the other side. And two creatures came up, and they came up and they walked up, they had four legs, and they went over to the four-legged animal side, and they said, you know, we would like to play in this game of lacrosse with you. And the four-legged animals captain came up and looked at the creatures and said, well, you know, first of all, we've never seen you before. You're very small, you're kind of unique in a way, and we really don't know what you are. And so the captain went back to the rest of the animals and said, you know, we have two creatures, and let's talk about, should they join our team? And the captain went back and said, you know, well, we don't know what you are, so we're unsure about this, what's going on. And if you think about that, that's kind of what we're going through right now too. We're coming into this unsure creature thing that we're looking at. It's novel, it's different, there's explanations for it, there's a lot of information. But the thing is, these creatures were resilient, and they had courage and said, well, we're not going to give up. We're going to go over to the bird side and asked to play in this very important and game that's being going to be played tomorrow, the next day. And so they went over to the birds, and the captain of the birds said, well, let me discuss with the rest of the birds to see if, you know, you can join our team. And so they did discuss, and the captain came back, and the captain said, yeah, you know, we'd like you to play on our team. We don't know what you are, but with your strength and resiliency, you came to us in a way that you wanted to be part of this, and that we know that this lacrosse is medicine. And so they said, we had to make 2 revisions to you, one to you and one to you. And the first one, they put the captain and the birds, they tied a drum leather to the back of the animal, the small animal. So that small animal became what's now known as a flying squirrel. It has 4 legs, but the ability to fly. And there was a lack of drum leather. It was all gone. They couldn't find any. So they decided that they would pull on the other creature. And they pulled the skin off, and that creature became the flying bat. And so you look at, you know, 4 legs, and it has the ability to fly. And so the game was, the next day came, and they decided to play, and everybody was on this field. And back in the day, the first game, and even games, you know, from a long time ago, they were played on this huge field. You know, it isn't like today where it's a 100-yard field or an ice arena ice hockey arena, but it was a large field, perhaps miles long. So the game it took a long time. It could take days, maybe even a week or more, maybe even longer than that. And so the game began, and back in those days, the game went to 3. So they threw the ball up in the air, and right away the squirrel grabbed this ball, flew down, and took the ball and scored. And back in those days, you had a post that you had to either throw it this way or that way, or hit the post, and it counted as a goal. And so the game went on, and the second team scored. It was the other team, you know, the animal scored. So now it was 1-1, and the games back then went to 3. And so as time went on, it went on for a few days, and it was back and forth. Nobody scored. And finally, the bat grabbed the ball, went through, and scored the final goal, making the winged animals win this very first lacrosse game. And so the story behind that is, you know, there's a lot of things if you think about of our Indigenous stories. And in this one in particular, it talks about the diversity of things, that we here are sharing our different perspectives on science, that we have to be open to all these different things and be appreciative of all our different knowledges, Indigenous, non-Indigenous, science, our healers, our elders, our youth. Everybody has a contribution that we have for our societies. And it's important to understand that at this time, not to be afraid of this bat or squirrel, to actually, you know, embrace it in a way that now it's bringing all these new resiliencies and discussions and innovativeness to the way we approach things in our communities. And so I end with that story of really being open-minded, and that, you know, we bring all of our people together, that our diversity of mindset is important in the way that we approach all of our communities, the care that we're giving, and that we really put our minds together as one for each of us, but also our nations, our people, and across the world, that we are not afraid of this, that we will be resilient, and that we'll be strong, and that we'll overcome it. So Nyawe and Dani Ho. And that will conclude our webinar today, our virtual fireside chat. On behalf of Roswell Park and the New Center for Indigenous Cancer Research, and all of our panelists that have contributed this evening, we send much love and appreciation for all the work that you're doing. Nyawe, Nyawa, Mahalo, Kiora, Ekiaha, Aloha, all these different things we send your way, Miigwech. So we appreciate everything that you're doing in your communities, and keep up the good work and keep up the good health, good mind. Nyawe.
Oh, thanks.